Thanks, Lynn. Anand, over to you.
Thanks, Lisa, and thanks to Matt and Lynn and Joe. It's great to be here with all of you. Again, I'm Anand Parekh from the Bipartisan Policy Center, and I've been asked for a couple minutes to share some thoughts on three topics. First, to talk about how healthcare reform has impacted obesity treatment. No small topic there. I must say it is a little lonely waving the bipartisan flag these days, but we try our best. Second, to talk about perhaps some approaches policymakers might want to take when they, or individuals might want to take when they talk to policymakers about obesity treatment. And then third, I've been asked to share just some ideas that the Bipartisan Policy Center has vis-a-vis obesity treatment policy. So on the first, with respect to healthcare reform, and I'll just focus on the Affordable Care Act, since that is the law of the land, and many of these themes and points have been made by previous speakers today. I think the biggest improvement that has been made when it comes to obesity treatment is simply 20 million Americans now having access to a varying degree of obesity treatments, whether for some that's intensive behavioral counseling, and for others it could be pharmacotherapy, perhaps less so. For others it could be bariatric surgery. So depending on those 20 million people, 10 million in the Medicaid side, 10 million in the individual market, they are all hopefully being exposed to and have more access to a wide variety of obesity treatments. Of course, that differs based on insurance, as you all have talked about today. I think in the area of behavioral counseling, and particularly intensive multi-component behavioral therapies, that's where, from a uniformity perspective, we've probably seen the greatest gains. So as you've talked about, Section 2713 of the Affordable Care Act, requiring that all private plans on the exchange, off the exchange, employer plans must cover A and B U.S. Preventive Service Task Force recommendations without cost sharing, obesity screening and counseling being one of them for both kids or adults. That also applies to Medicaid expansion population, so the 10 million who receive Medicaid through Medicaid expansion from the Affordable Care Act. And then when it comes to the Medicare national coverage determination that Ted and Lynn and many have referred to just in the last few minutes, because of the Affordable Care Act, that is now a benefit without cost sharing. So in many ways, the Affordable Care Act touched on Medicare, private plans, as well as Medicaid, with respect to expanding access to behavioral counseling when it comes to obesity counseling. I do agree with some of the other speakers who have said, while many of those policies might seem sound, there's really little data, and we don't really know the impact over the last couple of years on what those policies have produced. In many cases, when it comes to the Medicare benefit, it's very true that there's been very little uptake, and we'll probably talk a little bit about why that's so. Beyond that, in the Affordable Care Act, there are a number of ways where obesity prevention and treatment policy were furthered, certainly through the Prevention and Public Health Fund and Community Transformation Grants. There have been a lot of investments trying to change policy systems and the environment in communities across the country. Certainly the creation of CMMI, which allowed the testing for DPP in the Medicare population, and now the expansion and integrating into the payment rule is a part of that. Obesity as a process quality measure is now part of most alternative payment models, whether it's ACOs or not, so at least screening is now on the radar for healthcare systems. And as Deidre, my colleague, mentioned earlier, Medicaid health homes, obesity is one of the conditions there. So there are a lot of different ways that at least when you focus on the Affordable Care Act, as a proxy for healthcare reform, at least for the last 7 years, that obesity treatment has been furthered. But we clearly need more data. We clearly need to build upon all of this. With respect to sort of policymakers and how you approach policymakers when you talk about obesity and treatment, Matt and Lynn are much more experts or better experts than me in talking about that. But for me, it's pretty clear. I think you need an all hands on deck approach. I think policymakers need to understand that there is no bigger health policy issue today than obesity. Obesity impacts costs, it impacts disability, it impacts chronic diseases in ways that really no other, whether it's a chronic condition or it's a comorbidity, does. And it's fine talking about the financing of the healthcare system. It's fine talking about delivery of the healthcare system. If you don't tackle obesity, which is, with tobacco, sort of the leading risk factors driving multiple chronic conditions and others, we're not going to solve any of our issues. We're not going to improve health outcomes. We're not going to reach really a sustainable healthcare system. So, and I think with obesity, as you all have talked about today, it's really a mix. It's the clinical side and the community side. Depending on the clinical setting and the four walls of the clinical setting, and folks like me to try to tackle obesity is really not going to do it. And it's the community side really where we're going to get the most bang for our buck, reinforcing the clinical side and all the policy systems, environmental change. We just recently argued in Health Affairs that the Trump administration should look at funding communities across the country to engage in policy systems, environmental change. Communities should offer up matching grants. They should select communities that are disadvantaged so disparities don't get worse. But this is sort of a high priority. And maybe that feeds into a couple of ideas that at BPC that we've been thinking about, at least at the executive branch level, that we think the Trump administration could focus on. One is really for Secretary Price at HHS to convene a secretarial task force on obesity that focuses on prevention as well as treatment. You know, in the previous administration, there was a lot done on obesity, you know, whether you focus on First Lady's Let's Move initiative or other things CDC and others did. But we really never had a high-level secretarial task force with agency heads focused on prevention and treatment, where you could coordinate activities of CDC and CMS and all of the federal agencies, and I think that would be very helpful. I think a second area is looking at delivery and payment reform and looking at quality measures CMS is using. It's great that there are process measures for obesity screening. Where we really need to move to, and NQF and others are starting to look at this, are outcome measures for quality. We really need to put providers at risk, hospitals, healthcare systems on the hook for the prevalence of obesity, for percentage weight reduction as well. It's not just good enough to screen. Once we do that, once we put providers at risk on the hook, then all of these evidence-based treatments that you all have talked about today can be further integrated in the healthcare system. There'll be more incentives to deliver those, and I think we'll see more progress when it comes to obesity reduction. And so those are just a couple of ideas that we have put out there. Again, I think you need a clinical focus and a community focus. There needs to be clinical and community integration. Obesity policy is certainly should not be a partisan issue. I think both Republicans and Democrats are equally invested in this. And there are a lot of ways that we can improve the system, which I'm sure we'll also talk about more.
Thanks.